Hello, everyone, and welcome to WEO Colorectal Cancer Screening Committee's sixth and last webinar of our series. This webinar is hosted by Expert Working Group Screening in the COVID-19 Era. Without further ado, I'm handing over to Global Chair Evelyn Decker.
Thank you so much, Alexandra, again for organizing all these webinars today. It's the sixth webinar already of the expert working groups. It has been great so far. I thought it was so nice to be able to join all of the working groups instead of having to choose just one or two. So today it's indeed the last webinar of the expert working groups, but in a week and 2 days, so May the 20th, we will have our plenary session, a large session with many great talks, and the program will be sent very soon to all of you, and we hope many people will join. So for today, we have the COVID-19 working group. And I'm really happy to introduce to you the 3 chairs of this working group, all ladies, but from different sides of the world. It's from America, it's Sravanthi Parasa. From the Netherlands, it's Iris Lansdorp, and from New Zealand, it's Susan Parry. And I'm really delighted with all the 3 of you as chairs. You have different fields of expertise, and I think you will be a wonderful trio to make this working group a big success. So I would like to hand over to you now and wish you good luck with this webinar. Thank you.
Thanks, Evelyn. I am Sravanthi Parasa. I'm a gastroenterologist based in Seattle in the United States. And together with my co-chairs, Iris and Susan, we will be leading the CRC COVID-19, the impact of COVID-19 on CRC screening across the globe. And with the help of our experts and our expert speakers, we are hoping that we will provide some understanding about the past, present, and the emerging areas of research and what we have learned during this COVID-19 pandemic and how it impacts colorectal cancer screening. So I will move on to Susan to introduce herself and bring us more insight. Thank you.
So my name's Susan Parry. I'm a gastroenterologist, but I'm also clinical lead of the National Bowel Screening Program in New Zealand. So all the decisions and discussions that we will have this morning were ones that I was very involved with. And in addition, we also have responsibility for monitoring colonoscopy provision. So we weren't just involved in the decisions about colorectal cancer screening, but also the provision and prioritization of colonoscopy. So this topic is very relevant to me and have appreciated the support of my WEO colleagues as we have made these decisions, and we certainly have a range of interesting talks this morning. I will now hand over to Iris to introduce herself and some other comments about the session.
Thank you very much, Susan, and thank you very much, Evelyn, for giving us the opportunity to have this very important working group. My name is Iris Lansdorp. I'm an associate professor at Erasmus Medical Center in Rotterdam, and my background is in decision modeling, so slightly different from the other 2 chairs, and I think that makes it a very interesting combination. As a modeler, I've been very much involved in some of the work that will be presented today, where we're going to look at what the long-term consequences may be of these disruptions to screening programs that we have seen. But before we go on to the presentations, I would like to give some housekeeping rules that we will have. As you may have noticed, Zoom's chat function and the raise hand function have been turned off. But of course, we were very interested in the questions that you may have or the comments that you may have for the speakers and for the discussion later. So please post your questions via the Q&A box. We will not have Q&A after each talk, but instead have decided to set time aside for Q&A at the end of the webinar. But please, during the presentations, log your questions as they come up so that we can, at the end, answer and direct all of them to the appropriate speaker as we move into the session at the end. Today's agenda, you will see four, I think, very interesting presentations. The first one by Carlo Senore on the International Cancer Screening Network initiative to monitor the impact of COVID-19 on colorectal cancer screening programs across the world. The second is a joint presentation by Tim Kortlever and Lucie de Jonge on COVID-19 and the Dutch National Screening Program, where the third will be by Eleonora Feletto, looking at the impact of COVID-19 on the Australian Cancer Screening Program and projections by the COVID and Cancer Global Modeling Consortium. And finally, Vaishali Patel will talk about the impact that COVID-19 had in North America and cancer screening there. As you can see from this, it's quite a global program, and also it's representing different initiatives that are already going on in the global field. And that brings me to the aims that we hope to reach with today's webinar. We want to provide you with an update on the initiatives that are going on already. And together with you as an audience, we want to identify gaps in research that have not been addressed yet, and that we as a WEO working group could contribute to. Also, one of the things we realized while the chairs were discussing together is how important it is to have a network for support once crisis hits, so that we can speed up decision-making in these types of crises. And we hope that we, with this working group, can set up such a network. And finally, we want to collect evidence and your expert opinion so that we can work on a position statements as WEO working group on what good catch-up and recovery of screening strategies are, and what things we should be doing differently when we have subsequent waves of the COVID-19, but also waves of other crises. So without further ado, I want to give the word back to Susan to introduce our first speaker.
It's my great pleasure to introduce Carlo. In fact, I don't think he needs much introduction to any of us. He brings a wealth of experience as president of the Italian group for the colorectal cancer screening initiative, and all of us have read many of his comparative effectiveness studies of different colorectal cancer screening strategies. I have valued Carlo's expertise and advice on many occasions, and I really look forward to what he is going to share today about this initiative, because we all have much to teach each other. So thank you, Carlo. Looking very much forward to your talk.
Thank you very much, Susan. I share the screen. Okay, yes. Thank you very much for inviting me to this interesting webinar. I have no conflict of interest to declare, and I will briefly discuss initiatives aimed to monitor the impact of COVID emergency on screening activity and screening outcomes. And I will then present the International Cancer Screening Network initiative about aimed to monitor the activity of screening in the restarting period following the disruption related to COVID-19. And I will present some preliminary results. This survey, conducted last year by Professor Halloran, is showing that most programs around the world stopped their screening activity in March in 2020, and that they started again their activity between May and July 2020. But the programs were often not able to restart at full capacity, as the volume of the procedure was lower, even without restricting the opening times of the screening facilities, as a result of the more strict infection control and physical distancing measures. Therefore, a part of the population will have a longer delay than the duration of the disruption. And we don't have real-world data about the impact of screening delays on morbidity, and therefore indication to inform decision-making for screening programs is coming in this first phase mainly from well-established and validated decision models. And modeling experts joined the forces in the COVID-19 and Cancer Global Modeling Consortium to simulate different scenarios of disruption and recovery strategies, and to predict both long-term outcomes and short-term and long-term costs and savings. Here is a recent paper comparing the result of different scenarios using 4 different validated models. And these results are really interesting because they are showing that the impact of disruption is related to the duration of the disruption. Longer duration, there is a larger increase in mortality, and also a reduced activity during the period following the recovery period following the disruption is amplifying the negative impact of the disruption. Also, the participation during the recovery period is negatively affecting the mortality, because a lower participation is associated with a larger increase in the death rate following the disruption. And finally, the impact is related to the catch-up strategy. Immediate catch-up can minimize the negative impact of disruption, but even a 6-month delay for all screening can substantially limit the increase in mortality following the disruption of screening. So this is an example of how modeling can help providing some insight on the what can we expect from these stopping following the pandemics. But in general, modeling results are suggesting that screening interruption would increase the number of late-stage cancers and may have a higher impact in the older age groups. Policymakers are also interested in the screening capacity requested for each restart strategy, and this is something that will be presented and developed in further analysis with modeling exercises. But the WEO COVID-19 expert working groups also proposed some indicators to monitor ongoing activity of the programs. And so we can use some established outcome indicator, the response rate to screening invitation, to monitor whether fear and concerns about the infection are limiting participation in different programs. And then the detection rate of cancer and advanced adenomas, and the state distribution of detected cancer. But it's also important to monitor the ongoing routine activity to monitor whether the backlog can be recovered, or at least partially. And then it's important to monitor the positivity rate and the interval between positive FIT or YKFBT result and colonoscopy, the waiting time. In fact, monitoring of established early outcomes and short-term indicators of screening performance may provide an input to inform and validate modeling results, and to assess the effect of measures implemented to restart programs and possibly increase the screening uptake. And also can provide information to estimate the long-term impact of the delay. Here is an example of a monitoring activity that's been implemented in Italy by the National Screening Monitoring Center. In 2020, between January and May, the screening activity was reduced by 58% as compared to the activity in the same period in 2019. It was about 3 months of regular activity, and it was still 53% lower in the period between January and September. The reduction in the number of exams was about 1 million, and based on the observed detection rate in the previous years, we can estimate that the screening during the first 9 months in 2020 missed about more than 1,000 colorectal cancer cases and 6,667 advanced adenomas. These lesions will have a delayed diagnosis. The International Cancer Screening Network, and in particular the Colorectal Cancer Screening Interest Group, which I am co-chair with Iris, is designed an initiative aimed to monitor screening during the COVID-19 emergency. This project is aimed to collect aggregated quantitative data about screening activity and outcomes using a standardized data template to calculate key indicators and activity and performance. The project is a part of a coordinated effort of ICSN to monitor the impact of pandemic emergency on screening, including a survey aimed to collect qualitative information about measures adopted by different programs in different jurisdictions to face the emergency and to eventually restart the programs, and the collaboration with the COVID-19 and Cancer Global Modeling Consortium. The data collection is aiming to collect information about volume of activity, invitation and examinations, participation, screening test results, compliance with colonoscopy assessment, waiting time for colonoscopy, and screening outcomes, neoplasia yield, state distribution of screen-detected colorectal cancer, and interval cancer rate. The data are stratified by sex, age, and screening history, and they are collected for 2020 and for the corresponding period in 2019 or 2018, depending on the reference year chosen for the comparison. The data collection will be repeated using the same template to monitor the progression of screening activity and the performance during the restarting phase. Here is the first table. The data provider can select the protocol, the test, and the interval, the reference year for the comparison, 2018 or 2019, and the period for data collection, the first semester or January to September, or even the entire year at some point. And here is an example of the data collection table. This is the screening test result, and we have the data stratified by initial and subsequent screening, by age group, and we have to report the individual screened, the positive screening test, and the negative screening, and eventually the inadequate screening test. And these data are collected for 2020 and for 2018 in this case, because this was the reference year which was considered for comparison. These are some preliminary results of this activity. At the moment, we have 6 programs providing data about the first semester, January to June 2020. Not all the data were included in this analysis because there was not yet the time to complete the analysis, and we still need to check some information. 3 programs are expected to send data within 1 week. So the number is growing. And here is the first data about the screening activity. The proportion of invitation, that is the blue bar, was reduced by 65 to 55% in the different programs. But the reduction of activity when considering the examination was lower. We had a reduction between 35 and 45%, but it's interesting to see that the volume of activity was lower in terms of exams for people aged 60 to 69 as compared to people aged 50 to 59. The waiting time for colonoscopy was increased. There is a substantial reduction of the proportion of people having the colonoscopy within 3 months from the FIT positive test result in all programs. Even the reduction is more limited in some cases. And all programs show an increase of the proportion of people who had not performed the colonoscopy in the period covered by the data collection. So maybe most of them are still waiting for an exam, but some of them might have refused examination. So there is the indication that the refusal rate might be increased during this period. The detection rate of colorectal cancer and adenomas is showing, at least in 2 programs, a reduction in 2020 as compared to the same period in 2019. And here we are considering the people having already performed previous negative examination, people at subsequent screening. And finally, we have some information about the state distribution of screen-detected cancers. This information is available for 3 programs. And we see that in 1 program, at least, there was an increase in 2020 of the cancer diagnosis in stage in advanced stage, stage 3 and 4. Sorry, there is a mistake here. It's 3 and 4 stage. In conclusion, the data collection is usually performed over the entire year. So providing data for a shorter interval, let's say 6 months, might be more difficult for data providers. This might explain the limited response rate till now to this data collection. And also we should consider the screening staff is still under pressure, so to devote time to collect and organize data in the way it is required for the survey, it might be problematic. But we could anyway achieve some interesting result. The quantitative data collection is feasible and the quality of the data is high. We can say that the regular monitoring of the activity during the restarting phase can provide useful comparative information. In particular, as far as we can see by now, examination coverage seems lower among older people. Compliance with colonoscopy assessment among fit positive subjects decreased, and the waiting time has increased substantially. And the stage distribution of screen detected cancer needs to be monitored, as we have seen some indication that the proportion of late stage cancer might increase. I would like to thank people who contributed to the preparation of this survey, testing the data collection template, and also, of course, the data providers. And I thank you for your attention. Thank you very much.
Thank you very much, Carlo, for an excellent presentation. And I completely confess that I'm not unbiased, but I'm really excited to see these first results of this survey. And I think I speak for both Lucie and Eleonora that they might also be excited to see these numbers, because this is something we can really use for a modeling later. And then I would like to introduce our next two speakers for the joint presentation, Tim Kortlever and Lucie de Jonge. Tim Kortlever is a physician and research fellow at the Amsterdam University Medical Center in the Netherlands, and he works closely with Evelien Dekker on new strategies in colorectal cancer screening. Lucie de Jonge is a junior researcher at my department at Erasmus Medical Center in Rotterdam, and she has a background in econometrics. She works mainly on evaluating and optimizing the Dutch colorectal cancer screening program in the Netherlands. So Lucie and Tim, thank you very much for your presentation.
Yes, thank you, Iris, and thank you, WEO, for the opportunity to speak here tonight. My name is Tim, as Iris said, and together with my colleague Lucie, I will discuss the impact of COVID-19 on the Dutch National Colorectal Cancer Screening Program. And I will look at the short-term outcomes, and Lucie will discuss the optimal strategies to mitigate the long-term impacts of COVID-19. Next slide, please. So the most important messages that I want to bring across during these presentations are, firstly, that we observed a decrease in colonoscopy capacity, which led to a large backlog of people due for screening. Secondly, if a program is confronted with a reduced colonoscopy capacity, then temporarily extending the screening interval up to 34 months has the smallest impact on life years lost in the long term. And thirdly, if your program is forced to decrease the colonoscopy capacity even further, then increasing the cutoff of FIT could be considered. Next slide, please. Before we dive into this issue, just a short overview of how our colorectal cancer screening program in the Netherlands is organized. Each year, we send around 2 million invitations to people aged between 55 and 75 years old. And around 70% of those people send their feedback. So that comes down to 1.5 million participants. And of all those FIT tests we analyze, there is 4.3% of those tests are positive, with a cutoff value of 47 micrograms hemoglobin per gram of feces. Then out of all those FIT positive individuals, up to 85% undergoes a colonoscopy. So that comes down to 60 to 70,000 colonoscopies per year. And in all those examinations, we find colorectal cancer in 6% and advanced adenoma in 30%. Next slide, please. Of course, those numbers are when things run very smoothly, and that cannot be said of last year. Here's a graph displaying the number of hospitalizations and deaths per day due to COVID-19 in the Netherlands in 2020. And you can see that we identified the first case late February 2020, and then we had a large first wave of cases in the spring of 2020, and then another wave, a smaller one, a second wave in autumn 2020. And with the prospect of full hospitals in March 2020, our government decided to temporarily suspend our screening program. And I've indicated that suspension here as the gray area. It runs from March 16 until June 3rd, so that's about 11 weeks. And this suspension meant that we stopped sending fit invitations. And besides that, we also asked people who had just received their fit invitations prior to the suspension to hold their fit and not to return it until the program restarted in June. If people, however, did return their fit during the suspension, we still allowed them to undergo a colonoscopy during the suspension. Next slide, please. So to assess the short-term effects of this suspension on the colorectal cancer screening, we conducted an observational study with aggregated data from the Dutch CRC screening program. And I've talked about this study already 2 weeks ago in the WEO Fit for Screening webinar. So I'm not going to tell the whole presentation again. For the details of this study, you can take a look at that presentation on YouTube. But for this presentation, I'm going to reiterate some of the findings of our study, which will provide a background for the results of my colleague Lucie. The first thing I want to take a look at is the impact of COVID-19 on screening capacity. And in our case, we looked at the capacity of the pre-colonoscopy intakes, which may be similar to the capacity of the colonoscopies themselves. In this graph, the green line is 2020, the orange line is 2019, and the blue line is 2020. And immediately it is clear that the capacity of the pre-colonoscopy intakes was much lower during the first wave of infections in 2020. So that's around March, April, May, and even June. And then after June, July, it slowly returned to normal. Next slide, please. So this drop in capacity influenced the decision to suspend our screening program and suspend sending the fit invitations, partly to avoid having those with a positive fit having to wait a long time before they could undergo a colonoscopy. And this can be clearly seen in this graph, which displays the number of fit invitations sent each month. You can see that the colors are the same, that in April and May, there are 0 fit invitations sent out compared to around 200,000 invitations each month in previous years. So when screening was again resumed in June 2020, the number of fit invitations luckily quickly bounced back to normal levels. Next slide, please. But of course, this had some consequences. And one consequence was that the people due for screening in this period didn't get their invitation and were forced to wait. And in this graph, I plotted the cumulative number of invitations against the cumulative average of the 2 previous years. So this graph basically shows you the backlog of invitations at each month. And you can clearly see that the backlog is the greatest in June, just when the program restarted. It was around 600,000 invitations, and then it slowly cleared until a little over 400,000 invitations in November 2020. Next slide, please. So in addition to this decrease in screening capacity, colonoscopy capacity, we also looked at the participation to colorectal cancer screening. And here you can see the participation to FIT per month for the 2020, 2019, and 2018. And you can appreciate that around the time the first wave of COVID hit the Netherlands, so February, March 2020, the participation decreased by up to 5 percentage points. Next slide, please. And similarly, participation to the pre-colonoscopy intake also dropped during the first wave with about 3 to 4 percentage points. And luckily, it quickly recovered in June 2020. So to summarize, the Netherlands experienced a large wave of COVID cases in the spring of 2020, and that led to 2 things. The first was a decrease in colonoscopy capacity and the formation of a very large backlog. And the second was a temporary decrease in the participation rates to screening. Now, in the Netherlands, the most urgent issue for us was the backlog. So we were asked, what is the best way to solve this and how can we cope with future disruptions? And to answer these questions, I would like to hand over the word to my colleague, Lucie de Jonge.
Thank you, Tim. So as Tim mentioned, we were able to catch up the backlog while also inviting regular invitations. And previous studies have shown that catching up missed individuals could mitigate this long-term impact. And also this study showed that the participation, it is important to keep the participation as high as before the pandemic. So that's good news for the Netherlands. But on the other hand, new waves of the virus are occurring and suspected. So the pressure on the healthcare increased after the summer again. So while we had a backlog that needed to be caught up, we also were having lower colonoscopy capacity. So that's why the Dutch National Institute for Public Health and the Environment asked us, what would be the best strategy to temporarily decrease colonoscopy demand, such that the impact on the long term is minimized? So what we did in this study is that we simulated the Dutch National Colorectal Cancer Screening Program via our microsimulation model MISCAN-Colon. And we compared different strategies for 30 months after the restart of the program. So what we did is that we applied 3 different groups of strategies. So first, we increased the fit cutoff from 47 to 50, 55, 60, and 70 micrograms hemoglobin per gram feces. Second, we skipped certain age groups, 55-year-olds, 63-year-olds, and even 2 age groups, 63 and 65-year-old individuals. And last, we extended the screening interval from 24 months to 28, 30, 32, 34, and 36 months. We ran all these strategies into our microsimulation model. And in this presentation, I focused on 2 outcomes. So first, of course, the colonoscopy demand in 2020 and 2021, but also in the long term on the life years lost between 2020 and 2050. So this resulted in 12 different strategies, and we've compared these 12 different strategies to a situation in which missed individuals were caught up, but there were no colonoscopy restrictions. So first, I'm going to take a look at the colonoscopy demand. So on this slide, I showed you a figure for the colonoscopy demand for 3 different strategies. So I picked increasing the cutoff to 60, skipping 2 age groups, and extending the screening interval up to 30 months. And why I want to show you these 3 strategies is that all strategies result in similar reductions in colonoscopy demand, more or less 20,000. But it is important to note that extending the screening interval to 30 months has even the highest reduction. But this is the impact on the short term, but what is the impact on the life years lost? That is shown on this slide. What you can clearly see is that the impact on the long term, and especially the life years lost, is quite different. The lowest impact on the life years lost is obtained by extending the interval to 30 months. So therefore, I'm going to take you with me to have a deeper look into extending the screening interval. So as mentioned before, we extended the screening interval from 24 to 28 up to 36. In this graph, I show you again the life years lost. And what can be concluded or seen from this slide is that up to 34 months, the life years lost is comparable around 1,500 life years lost. While with an extension to 36 months, the number of life years lost is substantially higher. So the next question is then, but what is then the impact on the short term, the colonoscopy demand? Because that's our first outcome that we're interested in. And that can be seen on this slide. So, which is obvious is that with the extension of the interval, the number of the reduction increases. But what can be seen here is that with an extension from 34 months to 36 months, this results in 10,000 extra or less colonoscopies. But as seen in the previous slides, this resulted in substantial increase in the life years lost. So what, if extra reduction is necessary after the extension to 34 months, we advised the RIVM that we can also increase the cutoff additionally to, for example, 55 micrograms hemoglobin per gram feces, which will result in 2,500 extra life years lost. But as can be seen in the green bar at the top right, this would still mean that we have less life years lost when we extend the screening interval to 36 months. So concluding from this presentation is that in the Netherlands, there was a decrease in colonoscopy capacity, which led to a decrease in the number of FIT invitations. But also, if programs have a FIT-based screening, that temporarily extending the screening interval up to 34 months has the smallest impact in the long term. But on the other hand, if extra reduction is necessary, increasing the cutoff value could also be considered. And more importantly, from this presentation is that these findings are obtained in these times of this pandemic, but could also be used in other situations where screening is need to be disrupted, or you want to avoid the disruption and have restricted colonoscopy capacity. So there, I would like to thank all our co-authors for this work, and if you have any questions, we are happy to answer them.
Thank you very much, Tim, and thank you very much, Lucie, for this excellent presentation, clearly showing how important it is to mitigate or to avoid a backlog, and also ways that you can handle a reduction in colonoscopy capacity without having too much long-term impact. And in fact, our next speaker, Eleonora Feletto, will go into this a little bit more, looking at alternative scenarios that we have modeled as part of the COVID and Cancer Global Modeling Consortium. Eleonora leads the Gastrointestinal Cancers Policy and Evaluation stream at the Daffodil Centre, a joint venture between the University of Sydney and Cancer Council New South Wales. Her current work focuses on prevention and early detection of colorectal and liver cancer in Australia and overseas. And she has led numerous evaluations of Australia's National Bowel Cancer Screening Program to advise government on colorectal cancer screening activities. Eleonora, the floor is all yours.
Thank you so much, Iris. Thank you for the invitation to speak to you today. I'm honoured to be presenting this work on behalf of the team and as part of the COVID and Cancer Global Modelling Consortium. Specifically my colleagues who are working in the colorectal cancer screening space. So this is some work that we've been doing over the past 12 months. It's been referenced a couple of times, so I'm looking forward to sharing that with you in some more detail. So before I got into the results, I just wanted to go through the COVID response to colorectal cancer screening. So it's uncontested that the pandemic has placed considerable pressure on existing health infrastructure. And the figure on the right is a slide from a recent paper by Dr. Basu and colleagues mapping COVID infections over time at the bottom of the figure, and the related impact on screening capacity and screening priorities as you look from the top to the bottom. And it's clear from this that screening was initially strongly compromised, with the priority being on managing confirmed cancer cases. And the focus for some countries is starting to shift to how the backlog of unperformed activities can be addressed, especially for high-risk patients. For any country, the response to cancer screening and the potential to restart needs to be setting specific. Being able to predict the impact of hypothetical adaptations is a very insightful way for policymakers to decide on their approach. And in this case, and as we've seen already, modelling can be used to estimate and predict possible future outcomes and can be a very powerful tool. So in April 2020, the COVID and Cancer Global Modelling Consortium was established. It's one of 3 streams of work being conducted under the auspices of the COVID-19 and Cancer Task Force. The CCGMC's aim is to help configure modelling platforms and teams that can provide more informed advice to our governments specific to cancer. There are 3 working groups as part of the CCGMC, and I'll focus on working group 2 in the middle of this slide that covers a range of cancer screening programs, and one of which is colorectal cancer. This particular program of work brought together 4 teams across 3 countries with country-specific colorectal cancer natural history models. These countries and their models are Canada and Oncosim. In the Netherlands, we use 2 models, the ASCA model and Miscan colon that was used in the previous slide, in the previous presentation, and Australia, where we use Policy 1 BAO. All countries offer biennial fit tests as part of regional or national organised programs for people aged 50 or 55 to 74 or 75. In Canada and the Netherlands, screening was completely paused at the onset of the pandemic. In Australia, on the other hand, the national program has not been officially paused at any point. As part of the CCGMC, our 4 groups came together, and to date we've conducted 2 analyses that I'll now take you through. The first project has been referred to a couple of times, where we evaluated the impact of a set of hypothetical disruptions to colorectal cancer screening due to the COVID-19 pandemic, and we projected the long-term cancer incidence and mortality outcomes over 30 years. The paper has now been published in Lancet Gastroenterology and Hepatology. This figure depicts our approach to modelling hypothetical disruptions. The disruption could last for a given number of months. There is also the possibility that in the period directly after the disruption, efforts are made to provide catch-up screening to people who are missed, as well as continuing regular screening, or that participation in the screening program reduces after a disruption due to a reluctance of individuals to screen. So we modelled combinations of disruptions and the after effects. From this first project, here are some selected results for 2 of these particular scenarios that were modelled. And the results here are from all 4 models. So you can see the breadth or the range of results in the different countries. In the blue, we assumed a disruption to screening for 6 months. After the disruption, we assumed no catch-up and a return to screening as before. In the yellow, it was the same disruption, but this time with catch-up. So on the left, you can see the short term, in the short term, there was a drop in the number of cases diagnosed in 2020 that ranged from about 1,400 to almost 1,900 cases. But with immediate catch-up, this was low. And this was as low as 773 colorectal cancer cases. In the long term, on the right-hand side, we can see that the additional cases and deaths were considerable, but averted when catch-up was used to mitigate disruptions. So reinforcing what we've already heard, this project concluded that screening should be continued if safe, but where disruptions are unavoidable, catch-up screening can mitigate, though not entirely remove, the risk of increased long-term incidents. So in the second project, we evaluated strategies to clear the backlog in screening. And in this case, we looked at a 3-month disruption. So as has been mentioned, colonoscopy capacity and demand is something that needs to be addressed and taken into consideration when looking at how we can possibly catch up from a potential disruption. So we did this in 2 ways. We looked at, in the first instance, the period over which this catch-up could be conducted. So instead of doing everyone immediately, spreading it over a longer period of time. And similar to what was done in the Dutch program, we looked at increasing the fit threshold. Now, this threshold, the starting point for the threshold was different across the different countries. So that increased proportionally in the different settings. As for the first project, we again used 4 microsimulation models in 3 countries. So these are the results for using Policy 1 BAL for Australia. And on the left of this graph, you can see the monthly change in colonoscopy demand during the recovery period that's required to perform the catch-up screening. So 0%, the middle, it refers to the usual demand that would have been expected without the pandemic. On the right, you can see the total number of excess deaths in 2020 to 2050 that can be prevented by performing catch-up screening. 100% means that all excess deaths due to the disruption are prevented. So the two main results are that when catch-up screening is performed at the regular threshold, almost all of the deaths due to the pandemic can be prevented. But if you look on the left, the additional colonoscopy demand is required to do so. So where there may be limited capacity, extending the recovery period to 12 or 24 months could be possible and still prevent most of the excess colorectal cancer deaths. The second main result is that if usual colonoscopy demand cannot be increased, or in this case, in fact, if it's lower than usual, 50% of the excess deaths can still be prevented by increasing the fit threshold that's used to perform the catch-up for a limited amount of time. Whilst these are the results for Australia, the other models observed a similar trend, and this work has now been submitted for publication. So the overall findings of this work were that optimal strategies are setting specific, as has been previously suggested, but catch-up screening of people who were affected by disruption over longer periods of time could avert most of the excess deaths and would require a small increase in colonoscopy demand. Increasing the threshold of the FIT test slightly over a longer recovery period could also help ease the pressure on colonoscopy resources. So in Australia specifically, excuse me, there was policy interest in understanding the impact of a possible disruption not only on the general population, but on priority population groups. While there had been no official pause, there were concerns that remained around access, availability, and willingness to undertake colonoscopies during the pandemic, both from a health system perspective, but also from an individual behaviour perspective. So we looked at these in a little bit more detail. For the priority group analysis, these groups, as determined by our Department of Health, are those groups that are targeted for improvement in their participation in colorectal cancer screening. And they include the list the groups listed here, I'd like to show you results for people who received their first screening invitation in 2020. So in our context, this refers to people aged 50 in 2020. It's an important group as we know that once people in Australia screen once, they are more likely to participate again. Also interesting in that they have a slightly lower risk than older people that are eligible for screening and are also eligible to screen for a longer period of time. So here we compare no disruption over a 12-month period with a 50% reduction in participation after the disruption with or without a catch-up approach. So the blue dot represents no disruption and the purple and the green dots represent a 12-month disruption with or without catch-up. In the short term, on the left-hand side, you can see that there was a 75% increase in adenomas missed or delayed in detection due to a 12-month disruption, regardless of whether there was catch-up or no catch-up screening available. There was also an interest in understanding if there was a stage shift in the long term, and we found that there was a 2 to 4% increase in cases detected at stages 2 to 4, and a small decrease in stage 1 cancers detected. For colorectal cancer deaths, a disruption with no catch-up would result in an 11% increase in deaths, but catch-up would reduce this to 4% over the period 2020 to 2060 in people aged 50 in 2020. So the other area of interest, given that there was no disruption in Australia, was also looking at colonoscopy. And as a proxy for access, availability, and willingness to undertake colonoscopy, we also modelled the change in colonoscopy compliance rate. So the number of people who did present for their colonoscopy after a positive FIT test. This modelling was done for the general population, and what it shows is that at different levels of compliance, there is a long-term impact on the additional cases and additional deaths. If we take, for example, the 50% drop in colonoscopy compliance, which is represented in our case by 35% compliance to colonoscopy, we see that there would be an increase in CRC cases by 2,500 and result in approximately 1,200 more deaths. This indicated that even when there are no official disruptions to a program, recovery strategies do need to be considered. So for Australia, the key messages were that disruptions by priority populations depended on both their original participation levels and CRC incidence and survival rates in that particular group. Even if there is no disruption, changes to colonoscopy follow-up rates would have a significant impact on outcomes. And with that, I'd like to thank you for your attention and acknowledge that I am presenting on behalf of the largest colorectal cancer screening working group of the CCGMC, and to thank all of the members, especially the co-chairs, Iris and Karen Canfeld, and also my co-authors who are on the call today. Thank you.
Thanks, Eleonora. That was very great presentation. We learned a lot about what's going on across the globe there. And now I will move on to the Americas. And it's my pleasure to introduce Dr. Vaishali Patel, who's an assistant professor of medicine in the Division of Digestive Diseases at Emory University School of Medicine. And she's also an attending physician in advanced and therapeutic endoscopy at Emory University. Dr. Patel also has MHS with clinical expertise in pancreatic biliary diseases and bariatric endoscopy, and her research interests in gastrointestinal outcomes research and quality improvement as well. We are very grateful that she's here. She does have a high volume clinical practice and treats patients with biliary disorders, pancreatic cancer, and pancreatitis. She also has a special interest in bariatric endoscopy and primary endoscopic methods for weight loss and bariatric complications. Now, during the COVID-19 pandemic, she was actively participated in, and their group conducted research exploring the GI manifestations of COVID-19 and the impact of the pandemic on endoscopy practice itself. Thank you, Vaishali. I'll stop now.
Thank you so much for having me. I really appreciate being here and being a part of this group. It is really quite humbling for me and so exciting and fascinating to hear about what's going on in other countries when it comes to colorectal cancer screening. I'm going to be presenting some data on behalf of the North American Alliance for the study of digestive manifestations of COVID-19. It is a group of us that are all different institutions in America, but felt the need to come together to look at the impact of COVID in America. And I especially want to thank our principal investigator, Joe Almunzer, who is in South Carolina at the Medical University of South Carolina. And I don't have any relevant disclosures. So in the talk today, we're going to be reviewing the impact of the COVID-19 pandemic on endoscopic volume in North America, and then also discussing the potential downstream consequences on colorectal cancer, specifically in the United States. As you'll see by the end of my talk, I think I'm going to highlight some places where the United States probably has some catching up to do with regards to our screening programs in terms of what's going on in the rest of the world. So this is basically a graphic from our first study that we put out in the spring. So as you all know, as was the case globally, to conserve healthcare resources and to redirect them towards efforts against COVID-19, in March 2020, the American Cancer Society recommended postponing cancer screening plans. As such, endoscopy units basically then prioritized doing necessary procedures only and postponed non-urgent procedures. Screening colonoscopies really did bear the brunt of this. Again, since we don't have a nationalized healthcare program, this was really the decision of private hospitals stopping and starting endoscopy based on their own feelings about the safety and prevalence of disease at their time. And so depending on the region and the local prevalence of disease, endoscopy centers reopened at varying times. But on average, most were closed for about 6 to 10 weeks in the spring of 2020. So our initial survey that we did was conducted in April to May of 2020 and really established that 2/3 of centers were operating at less than 10% of normal endoscopy volume during that time. Most of them had actually stopped completely for a short time, but overall, there were many practices that continued to offer endoscopy, but at lower than normal volumes. The bulk of the postponed procedures, like I said, were mostly screening colonoscopies, and this largely impacted ambulatory surgical centers rather than hospitals, as they were more likely to completely stop endoscopy. So plans for the resumption or reactivation of endoscopy, again, really differed based on local community prevalence and then also based on the availability of resources. The top 3 factors that we found that influenced the decision to resume elective procedures in the early stages of the pandemic were decreasing community prevalence of COVID, PPE availability, which was definitely a huge problem in the beginning of the pandemic, and then also availability of pre-procedure testing. When we asked the participants to identify barriers to increasing endoscopic volume during the early part of the pandemic, practices cited their capacity for pre-procedure testing as being the biggest barrier. The vast majority of practices, or 83% of practices, planned to do some sort of screening for COVID-19 prior to procedures. And really, at the beginning of the pandemic, this really highlighted a need for better testing to become available, given that testing was identified to be such an important factor for the resumption of endoscopy. The other frequently predicted barriers for increasing volume in the early stages of the pandemic were patient fears of COVID exposure, and then, as I said previously, limited PPE supply. So with this in mind, we'll look at the data from our follow-up survey. So 120 of the practices that had responded to our initial survey in April of 2020 then responded to a second survey between August and October of 2020. So this was later in the pandemic. 82 of the practices responded, which resulted in a response rate of about 70%. There was representation from some Canadian provinces, and there was an even distribution between ambulatory surgical centers and hospital-based practices, as well as urban versus suburban practices. And the COVID-19 incidence data was extracted from a private database that's housed by Johns Hopkins University, and we basically collected it just for the county or the Canadian province in which the practice was located. So as you can see here, later in the pandemic, still only about 1/3 of practices reported operating at or greater than 100% of their pre-pandemic volume. The large majority of practices were still below usual volume, and about 20% remained below 75% of usual volume, which is quite a significant number, especially when considering that most of these, as I said, were ambulatory centers with the bulk of their volume being screening colonoscopies. We also then asked practices to identify what their top 3 barriers were at that point during the pandemic. And again, about 70% of practices experienced ongoing barriers to increasing volume. The 3 most commonly identified barriers were patient fear of COVID-19 exposure, inconvenience of pre-procedure testing for patients, and then also increasing COVID-19 prevalence as we started to head into a second surge in the fall of 2020. Our group is currently in the process of collecting some follow-up data. Now that we are months into the vaccination process, we're hoping to see that there has been some recovery in endoscopy volume as vaccination rates improve and the disease incidence of COVID-19 plateaus and hopefully reduces. Here in the States, we really have not probably started to see that until 2021 because we experienced really quite high surges of COVID-19 disease during the fall and over the Thanksgiving and Christmas holidays. And so really now we're hoping that we start to see both the incidence decrease as our vaccination rates increase. There is still work to be done as far as vaccination is concerned in the United States. There remains a significant portion of the population that is unvaccinated, both due to difficulties in access to vaccination as well as patients actually declining vaccination. As of 6 a.m. yesterday, when I last checked, over 3 million vaccine doses have been distributed in the United States. 80% of those have been administered. That basically translates to 46% of the US population having received at least 1 dose of the vaccine, but only about 35% of the population being fully vaccinated. So in the background of this, we have to remember that prior to the pandemic in the United States, colorectal cancer screening rates were slowly increasing. However, there was still a need for further improvement. By CDC estimates, at least a quarter of adults were not being screened appropriately as of 2018. In 2019, the colorectal cancer screening rate in the United States was about 45%, which we have to keep in mind because in October 2020, the United States Preventive Services Task Force drafted a recommendation to start colorectal cancer screening at age 45 instead of at age 50, which was previously recommended. This new recommendation was consistent with that of the American Cancer Society, which actually had already lowered its recommended age for screening from 50 to 45 in June 2018, 2 years prior. This new recommendation makes over 20 million Americans between the ages of 45 and 50 newly eligible for screening. And this is in addition to the backlog of patients from COVID-19 related pauses in screening. So this just really highlights a need for a new national public health strategy to ensure that those who are highest at risk for colorectal cancer screening are actually prioritized. So screening colonoscopies actually in the United States are really the mainstay of colorectal cancer screening, and that might exacerbate the impact of colorectal cancer screening or the impact of COVID pandemic on screening in general. Unfortunately, because the process of getting a colonoscopy has become a little bit more complex. So certain things that are necessary, such as pre-procedure testing for COVID-19 infection, increasing levels of hygiene measures, social distancing throughout the waiting rooms and recovery rooms, all increase the amount of time that is required per procedure and also limit the number of people that can be accommodated in the endoscopy unit. So there are certain estimates from this publication, for example, from World Journal of Gastrointestinal Oncology, estimates that a moderate 7 to 12 month screening delay will cause a significant increase in advanced cancers at detection, increasing from 26 to 29%. If the delay worsens for up to 12 months, that actually worsens to 33%. These estimates suggest that a delay past 6 months is going to result in a shift towards more advanced stage in detection, as well as a delay past 12 months resulting in an increase in mortality rates. And as everyone knows, these effects will increase both disease burden as well as the cost of the disease. So as far as trying to deal with this in a public health strategy, there have been some calls in the United States to back away from screening colonoscopies and start to increase the utilization of FIT testing to triage and also to help reduce the backlog of patients who need to be screened. Since FIT is a non-invasive procedure, as we all know, might be a way to reach patients who are hesitant of coming into the hospital for a perceived risk of contracting COVID-19. And of course, as we all know, FIT also has a high negative predictive value, which might help for it to be an appropriate test to triage some symptomatic patients. Earlier this year, a simulation model was actually created in which COVID-19 related reductions in care utilization resulted in significantly fewer colorectal cancer screenings, fewer colorectal cancer diagnoses, and also reduced diagnoses at early stage between 2020 and 2023. So they were basically simulating, what's going to happen to cancer screening if things remain how they are currently in the United States. They then created 4 scenarios in which colonoscopy screenings were reduced for varying periods of time, as you can see in this table, and then increasing in FIT testing also over a 3-year period. And what they found was that increasing the FIT test use was associated with an estimated additional 600,000 colorectal cancer screenings and almost 3,000 colorectal cancer diagnoses, of which 70% would be early stage diagnoses. So these results suggest that in the United States, if we start to use FIT testing more, especially while the pandemic is continuing to linger, it hopefully will be associated with increased colorectal cancer screening participation, but also increased diagnosis at earlier stage. The other option or another approach is also considering increased use of other stool-based DNA testing. So in the United States, Cologuard is very popular. This is conducted at 3-year intervals instead of 1-year intervals, such as FIT. And that also may potentially be preferable to patients and reduce hospital burden as the backlog of patients needing screening increases. The other advantage of DNA testing is the presence of a patient navigation service, which ships kits to patients' homes and then returns them directly for processing. It doesn't require any special preparation or time off from work. And so it poses to be a convenient service to use during the pandemic. Of course, we do have to remember the important limitations of these tests as well. So stool-based DNA testing, as we all know, does have a higher false positive rate, and they're also not as effective as colonoscopy for the detection and removal of precancerous lesions. But again, in the effort of increasing screening methods, this may be a good, viable alternative approach. Most cancer screening in the United States also operates on an opportunistic visit-based model. So basically, patients get captured for screening as they present to their primary care provider or as they present to GI providers. However, in the wake of the pandemic, we're starting to see that there is a growing need in the United States for the implementation of organized cancer screening, independent of in-person clinic visits. There really needs to be an organized national outreach effort, which will probably be much more effective than provider-initiated screening. This study that was actually published from a center in San Francisco, California, shows the change in screening patterns from just one health system with increased use of FIT testing as well as telephone visits. And it actually shows improvement in colorectal cancer screening rates from 40% to over 80% just after implementation over 1 year. And time will tell how these interventions impact the burden of colorectal cancer in the United States. It's obviously very important here. It's the third leading cause of death here, which is something important to consider, especially as the pandemic continues to linger. The healthcare crisis here has also underscored persistent inequities in the United States, including the highest rates of COVID-19 infections and deaths in African American, Native American, and Hispanic communities, who unfortunately, as we all know, also have the highest rates of colorectal cancer-related deaths and already have lower screening rates than other ethnicities. So for medically underserved populations that already have limited access to preventative health services, the loss of being able to pick up FIT or FOBT cards in person, or getting access to colonoscopy when endoscopy centers may already be strained, is going to make completing screening even more challenging now. And this will likely remain the case for some time. Among medically underserved populations, research participation is also further challenged because they have less access to digital platforms, disproportionate unemployment, unstable housing, and in many cases, they continue to need to be essential workers. So it's very, very important that here in the US, we continue to engage with these communities and also harness the power of social media and also virtual platforms to promote the message of paying attention to these populations and not allowing the disparities in screening to worsen in the wake of the pandemic. Decision-making about attendance for endoscopy procedures and how patients assess their risks is actually probably quite poorly understood. In addition to fear of exposure to COVID, patients also experience family pressures, logistical considerations, such as career responsibilities and childcare, and travel to and from the hospital while adhering to social distancing. And here in the US, there's also somewhat of a cultural difference in that many patients perceive their risk of COVID-19 and the risk of dying from it as being very high and quite real, whereas the risk of colorectal cancer is really just considered a potential risk if it's diagnosed. So it's very critical that we explain all of these risks to patients, in addition to the message that earlier cancer diagnosis makes it much more likely to be curable, and also important to explain all the safety measures that endoscopy units are taking to minimize transmission risk of COVID, and help to reassure them, as well as emphasizing that the risk of a late cancer diagnosis probably hugely exceeds the risk of actually catching COVID-19 infection at the event of an endoscopy. So in conclusion, the pandemic really presents a unique opportunity, I think, for the United States to start to transition from its current largely opportunistic screening approach, defined as screening offered by a provider, to hopefully a more organized national programmatic approach. And while the COVID-19 pandemic has been a major disturbance to colorectal cancer screening, hopefully this disruption results in some beneficial changes to the current screening strategies to improve access to screening and provide more convenient options, which will hopefully result in better compliance. So thank you all for your attention, and I'm happy to take questions.
Thanks, Vaishali, for that excellent presentation. I mean, yeah, hearing from different parts of the world, we understand what perspectives we have and how things happen here compared to how it is run everywhere else. So at this point, I'm just looking at the Q&A, and it appears that we don't have any questions. So that means we can move on to the discussion, Iris and Susan, because I think each of the expert speakers actually raised very interesting points as to how to deal with this, these kind of situations in the future, and what can we do better as we move forward.
Yes, if I may follow up on that, Sravanthi. One of the questions that I had is for the last speaker. I think coming from Europe, we are strong believers in fit-based screening, of course, but I also have concerns about the acceptability of fit in US settings. Can you comment on that? Do you think that indeed fit as an alternative to colonoscopy, especially to the medically disadvantaged groups, will be acceptable in the US?
That's a fantastic question, and I think the thing that we're sort of, struggling here with, and Sravanthi, jump in as well if you have an opinion on this, with our colorectal cancer screening rates not being, optimally as high as they probably should be to begin with, I think what the pandemic has taught us is that some screening is better than no screening. And so because there tends to be a sort of a cultural, especially in some populations, notably African Americans and Hispanics, there's a lot of distrust of the medical community, distrust of hospitals, and distrust of medical care in general. A lot of those people don't come for colonoscopies and then end up getting no colorectal cancer screening. So if an increase in FIT utilization or even stool-based DNA testing can help to mitigate that and at least provide some screening compared to no screening, we're hoping that that then results in earlier cancer diagnoses.
Thanks, Vaishali. I think I agree with you. It's any screening versus no screening, right? So that's pretty much the motto. If a person is not having access to colonoscopy or has some reservations to undergo a colonoscopy, whether it's COVID related or unrelated, I think alternative ways for diagnosing or risk stratification of these patients from a colorectal screening standpoint has to be done, and highly encouraged in primary care settings as well. And I think we do have a question. So it's from Linda Rabenek. So aside from changes in the FIT cutoff, it is interesting to consider different approaches to catch up. Do we have any thoughts or any other ideas regarding that?
I thought maybe, Eleonora, you might want to comment on that as a start, since we've done some alternatives as well, looking at sort of prioritization.
Yeah, thanks, Iris. We certainly have had very robust discussions about prioritization and what might be useful. I guess before I go into that, one of the reasons we did land on the fit threshold is that at least theoretically, it would be something from a programmatic point of view that would be that could be quite simple to change. Some of the other prioritizations was looking at different age groups. And I think Lucie also mentioned in her presentation in the Dutch program where they looked at they identified particular age groups. So I guess there are alternatives that are available. How easy they are to implement. I know in Australia, we do consider the messaging that goes behind the program. We have a national program that's available that was only fully implemented as of last year, which coincided unfortunately with the pandemic, and we have a 40% participation rate. So our emphasis has been on increasing participation rate, and as has previously been mentioned, getting anyone to screen rather than, so programmatic changes at the moment are not something that are as possible from a practical sense. But Lucie, perhaps you might want to comment on some of the additional analysis that you led.
Yes, thank you, Eleonora. Well, to clarify, we skipped certain age groups, so we didn't cut them up. But yeah, you're right. That could also be possible strategies. And for the Netherlands, the screening organizations were actually quite happy with our outcome to extend the screening interval, because that was the easiest thing to do in our case because of our IT system. And also, if you skip I agree with you, Eleonora, if you skip individuals, the message might be a bit complicated and ethical, not right to do that. So yes, I totally agree on that.
Lucie, can I ask you a question? In your graph, you had the very steep increase in impact from 34 to 36 months compared to all the other increases. Can you just explain that to me? Because I'm struggling a little bit to understand that. And whenever you see dramatic increases in data, you always look for what the explanation is. So I'm keen to hear your explanation for that.
As well, thank you for asking that, because we have been looking into that, why this increase was so substantial. So we looked at the colorectal cancer diagnosis, and up to an interval of 34 months, we see that the number that we prevent at the older ages, because with an extension, you slightly invite individuals at older ages. So the number at older ages is higher compared to the number that you additionally have at the lower ages. So, and looking into our model outcomes, we saw that with an extension of 36 months, there was a shift. So the number prevented at the older ages was not higher anymore for the ones that were additionally diagnosed at the younger ages. So that explains this shift.
Thank you. I've just got one other question, Iris, and then I'll hand back to you. I think the presentations have illustrated the multifactorial approach that is necessary to managing this. Vaishali, your focus on what stops people delivering colonoscopy was very important, because, and you need the joined up approach, because when you're also responsible for colonoscopy delivery, the whole questions about PPE and providing prioritization of who should proceed to colonoscopy took quite a bit of time, and that needs to be addressed, because that also impacts on the colonoscopy capacity for screening. So I think the talks have highlighted for us that we cannot sit in our silos, that we do need to be engaged across all the things that impact on colonoscopy delivery. And the other thing is the importance of real-time data on the availability of colonoscopy. Your Dutch obviously knew your screening slots that are available with clear accuracy, but that availability of real-time data, and also the importance of monitoring our priority populations, because we started monitoring the number of weeks that people were waiting for colonoscopy after our pause of 3 months. And it became very clear that we had to monitor that by ethnicity. So tracking that, so to satisfy all the concerns, both of our participants and our health providers and the physicians delivering colonoscopy, these talks have illustrated that we really must be joined up. And to have the data that you've provided for this impact has really been absolutely fascinating.
Yes, thanks, Susan. I think I totally agree. That's very important. And one of the reasons to this, that I really like the prioritization question by Linda, is also that it's not just within the screening program that you can prioritize, but as you say, it's a multifactorial problem, and you can also prioritize outside of this screening program. And I think that's what we've been having discussions about as well. Maybe we should delay surveillance exams for which we know that the yield is quite low, and focus more and prioritize positive colonoscopies after positive fits. But I know, Carlo, that you have a strong interest in a more personalized fit-based approach. And of course, one of the things that we've been discussing is, would this COVID, the silver lining of this COVID pandemic, be that we can start implementing this approach sooner? And is this now occurring in Italy, that you're prioritizing based on prior fit results?
Yes, thank you. I wanted to, in fact, to comment on this issue, because in fact, prioritization may be based, for example, on age, as it has been suggested. You might prioritize older age groups, as the expected impact might be higher, as the models are suggesting, and also because there is a higher prevalence of the disease. But screening history might be an opportunity to stratify by people based on the risk that you can derive by screening history. The approach that we have been considering is considering the amount of hemoglobin among those who are fit negative. We have some observational results showing that in Italy and in Spain, showing that there is a lower risk for people who have consistently very low fecal hemoglobin level at previous exams. And so we can assume that it's possible to extend the interval in this case. These people is making up a fairly large proportion of those who are undergoing screening. And so you might reduce the number of invitations, postponing over the third year people who are due from the second year now. And we are introducing this as a research project in our region. We are going to start in the second semester of 2021. And in this research project, we will randomize the one person on 2 years and 2 people in 3 years in this low risk group, ratio 1:2. And so we will reduce the amount of invitation we need to perform in these in the next years, between 6 months and 1 year. This is also an opportunity to use this emergency as let's say, as a way to start research given that you have a backlog and you need to find some way to recover from this backlog, then you might use this opportunity to test different approaches for extending the interval. So this might become an opportunity for research, and I think it should be considered when thinking about strategies for recovering. That is, research approaches can be used. You can randomize people into different intervals, for example, to different cutoff or to different age groups and so on. So it's, I think that is important to consider also this opportunity for research. But, and in fact, in our jurisdiction, in our region, we are using this research approach to try to recover from this backlog, extending the interval for a subgroup of population. Yeah, that's what we are going to try. Yeah.
Great.
Yes, I did have one question. And this is just out of curiosity. So one of the points that Dr. Patel brought up is, at least in the United States, it's not the access to colonoscopy, because it looks like the volumes have dropped. It's more the patient perspective of the perceived risk of COVID-19 if they undergo a colonoscopy at this time, right? So I'm just curious if that kind of perspective among the patients exists in the rest of the world, meaning are you truly seeing influx of patients into endoscopy because there was a backlog, or is it just a thought?
I think it certainly existed in New Zealand, and the DNA rate for the do not arrive rate for colonoscopy procedures increased, and therefore that further reduced utilization of the theatres. And following resumption of our screening, the first thing to look at was the fact that the colonoscopy volumes waiting to be done was lower. So we immediately knew people weren't participating. And we had to then actively, particularly with the priority populations, work to encourage them to participate. So you make a great point. Again, we can't work in silos. We have to work also in the community to get people to participate and to address those fears. And that's something we discussed, Iris, isn't it? And the expertise in the right ways to address that.
Yes, that actually makes me wonder, looking at the Dutch data, Tim, we do see a decrease in participation temporarily with colonoscopy, but then we seem to catch up in the end. Did we do, and I honestly don't know, did we make any changes to our program or to the colonoscopy setting that helped us get the colonoscopy participation up again?
Well, I briefly spoke about this with the head of the National Organization for Screening in the Netherlands. And she also said that there wasn't really a campaign promoting screening or for some sort. There was a media campaign of the Cancer Society to go to your GP if you had symptoms, but not screening specifically. And with regard to changes in the program, I'm not aware that most endoscopy centers did any changes. I think they could have done some telephony pre-colonoscopy intake, but as far as I'm aware, the colonoscopies were done pretty much the same as before. And that's quite surprising that, as we saw in my presentation, that the participation rates bounced back quite quickly. I'm not sure where the differences, why these exist between these countries. But I think one factor is that in the summer, we had it under control, the COVID situation, and then you saw the fear in the population quickly go away, and everyone was quite eager to go out and to do things again, and also to participate in screening, apparently. And I'm not sure how this is now during the second and third and even the fourth wave we're having at the moment. I don't have these numbers, but about last year, it's surprising that it bounced back so quickly.
Tim, I think you you really just hit the nail on the head there with that point. I think the key really was the control of prevalence being better in so many other countries across the world compared to what it was here in the United States. For us, when we were at the end of that period where we had paused endoscopy and we were talking about resuming endoscopy or reactivating endoscopy, unfortunately, it didn't correlate with a decrease in COVID prevalence. So our COVID numbers here over the summer, as they dropped in many countries, here they did not, for a variety of reasons. But I think that really played a role in, really still playing a role in people's minds to have that fear of coming for their procedures. And then it just continued into the fall for most of 2020. So I think that's probably really what we've really experienced here.
Thanks, Vaishali. I think that brings up an important solution. Maybe it could be what we need is a strong campaign globally to say that, you cannot stop, colon cancer screening just because something else is going on. These are the priorities, and having, as Susan said, instead of us being in different silos, have a equal, joint voice to kind of put that out so that the messaging is clear. And, depending on what type of testing is prevalent in each country, they can adapt to that particular testing. But I think the message should be loud and clear.
I see that we have one more question by Stephen Halloran talking about the definition of catch-up. And he says that there's actually two definitions. Catch-up can be providing screening to those who did not receive scheduled screening during the period when the service was stopped. And it's about the second definition is returning all screening invitation dates back to what it would have been without a COVID shutdown. And he was wondering about what the term catch-up means in the presentations of today. And I think maybe Eleonora, maybe you could say something about what we've assumed in our analysis about catch-up screening.
Yes, sorry. And Lucie might also want to comment. This, the way we've interpreted catch-up is screening the people who weren't screened, who did miss their screen during that disruption period. So, and then bringing and continuing on with regular screening. So based on those two different definitions, and perhaps Iris or Lucie may want to clarify, it seems more that it's number one rather than number two. Would you agree?
I think for the CCGMC, it is the second one.
Oh, right. Excuse me.
But I'm not sure, because for my presentation, we did the first one. Maybe I don't understand them.
Yeah, I wonder also about this distinction between the two. I think it's a combination of both, actually, in the sense that you have the backlog, you want to catch up. So the backlog is the people that missed the screening, but there's two ways you can deal with it. You can do everybody else at the same time that they would have been screened and just add the backlog on top of that. And I think that's sort of definition number one. The alternative would be to do the backlog first, but then everybody shifts aside. And then the total catch up would be that's including that period that you get back to normal again. And I think the first one is more like we've done for the Global Modeling Consortium, whereas the second one is more what we've done for the Dutch analysis, which the way that the Dutch program works is that it's a first in, first out principle. So first you do the backlog, and that will go at the expense of the people that would normally have been invited during this time. So everybody shifts by a certain period over time. but it's a very important point to make. Go ahead,
I was just
Eleonora.
going to say, I think Stephen raises an excellent point that the semantics of it are quite challenging to explain, but the principle of making sure everyone who was disrupted is screened at a certain period of time, within a given period of time is where we want to get to, is the aim. But thank you for raising that.
I think, on a very practical point, when we were looking at it, and one of the advantages of a small country is that you can have Zoom meetings with all the hospital unit chiefs who are delivering endoscopy. And you need to get their agreement about how you're restarting screening, unless you want a very a number of phone calls. And so in actual fact, when we look to restart in these phone calls with all the endoscopy leads of all the hospitals, the message was very, very clear. Don't you dare increase our volume. You can restart at the same rate, but you cannot catch up for us. And they said they wanted a minimum of 6 months before we started to increase volumes. And I have to say, it is only now that we are inviting the age outs. We just stopped completely for 3 months, and then we've just continued on as since. So we've just inviting the age outs now. And I think the other thing is, Iris, it dependent on your IT systems. We're running between 2 IT systems, an old one and a new one, and how they slot people into invitation strategies very deliberately in a chock-a-block, those games where everybody slots into a strategy. Your options for moving those around is quite a challenge. So I think it is important that we, Stephen asks a really good question. We need to talk about what we mean by catch up. And I think in New Zealand, essentially, we probably will catch up on the age out, but everybody else actually got pushed out a bit by 3 months, essentially.
Yes, and I think, Stephen, not just the semantics are important, but also the fact that countries, because of IT or because of other reasons, do it differently. And it would be a very interesting natural experiment to see what the long-term consequences of these differences are. Because Stephen is saying that England and Scotland are even different. Well, the programs are similar in other respects. So that's something that maybe for the long term would be interesting to look at what the impact is. In the interest of time, Susan, I think because we're losing people as well, do you want to do the sort of concluding statement of the session?
It's I think the value of this session has meant that many minds are much better than one mind, and many different countries' perspectives are better. And that's precisely what this WEO colorectal cancer screening committee delivers for all of us, particularly if we're in smaller countries. But even so, our different perspectives add significantly. And one of the things as chairs that we talked about was when we're looking at research topics or what we would do differently, one of the things that we thought of is that we should be having multi-country, multi-panel expert committees available quite quickly to make certain that each country is considering all the appropriate perspectives when we are making decisions with our own countries. So I think it just falls to me to thank all the presenters for the caliber of information that you have presented across the full concerns of screening, from the patient through to program delivery and program parameters, and also to thank the expertise of my co-chairs. And lastly, the WEO Secretariat, how you have rounded us all up in these different time zones and made certain that we joined all these meetings. I think you deserve a gold medal. So thank you again to everybody. Is there anything else you'd like to add, Iris or Evelyn?
No, thank you, Susan. For me, it is great. I really enjoyed the symposium.
Thank you, everyone.
Yes, thank you everybody for attending.
Thank you, everyone.
Have a good day.
Thank
good
you.
night. Good
Good
sleep.
night. Good everything.
Bye-bye, everyone.
Bye. Bye. Thank you very much.
Bye-bye.
Bye.
Thank you. Bye.
Bye.
Thank you.